So good afternoon, everyone, and welcome to our second session of our Public Health Alliance Regional Equity Learning Collaborative. My name is Ayanna Bennett. I use she, her, aya pronouns, and I'm the Health Equity and Justice Manager with the Public Health Alliance of Southern California. And I will be facilitating today's session with my colleague, Marley Williams, and I will go ahead and let her introduce herself.
Good afternoon, everyone. It's so wonderful to, I know most of you, Marley Williams, she, her pronouns, suite, Health Equity and Justice Manager here for the Alliance. And if you know me, you know I'm gonna say, if you're able to turn on your video cameras, if you're in a place and space to do so, it's always wonderful to actually see you all and be in conversation with you all visually in this virtual space. So welcome. We're really looking forward to today's session.
Great. Thanks, Marley. So for today's collaborative session, we'll be diving deep into conversations and learning about, the different levels of racism, taking a closer look at systemic racism and strategies that local health jurisdictions can take to address health inequities perpetuated by racism. We'll be covering historic and present day real issues that can be pretty tough to talk about and hear about. So I invite you all to take care of yourself during and after today's session. And I also hope that you'll enter this space ready to have open and brave conversations with one another around these topics. And before I invite Tracy to say a few words, I would be remiss if I didn't acknowledge the important context in which we are holding today's session. I first want to acknowledge that February is Black History Month. And just as important as it is to recognize historic and present day harms that are impacting Black communities across the nation, it is also an opportunity to celebrate Black history, Black lives, and Black excellence, not just this month, but every day. And the music that you're hearing today during our session is coming from a curated playlist from the National Museum for African American Music, and we can share that link with you all. There's some pretty good jams on there that we'll be excited to share with you today. And so now I'd like to introduce Tracy Delaney, Founding Executive Director, to say a few words.
Wonderful, thank you, Anna. Can you hear me? Wonderful. So I'm Tracy Delaney. I use the she, her pronouns. And good afternoon, everyone. We're really happy to have you here, and we're excited to see such a robust regional commitment to the work of addressing racism as a public health crisis. We want to thank you for joining us today. This is our second session in our Regional Equity Collaborative. And as Anna mentioned, discussions of racism are difficult conversations, and they're even more challenging to address in our public health practice. So we recognize the commitment you all are making to address this work by being here with us today and through your participation in the collaborative. We're also very pleased to be joined today by two nationally recognized public health experts and leaders, Dr. Ayanna Bennett from San Francisco Department of Public Health and Matias Valenzuela from the Seattle-King County Department of Public Health. We'll share more about our guest speakers as we introduce them during our panel. So we know that today's session will only begin to scratch the surface, and we want to assure you that the Public Health Alliance is committed to supporting you, our members, in this vital work moving forward. So thank you for joining us. And Anna, I'll turn it back to you.
Great, thanks so much, Tracy. And before we dive in, just a quick reminder that there are several points of Zoom housekeeping that we want to make sure you're all aware of. I won't go into great detail what's on the screen. However, I do really want to lift up 2 points. The first is we'd really love to see you. If you're in a place and space to participate with your camera on, we strongly encourage you to do so. Being able to see your faces, your reactions really helps liven up the feel of these virtual environments. Secondly, I want to take a moment to remind everyone that we will be recording today's session and that the clips will be available on our website after today's session. Recordings from our large group presentations, panels, and the Q&A will be available to view, but small breakout groups will not be recorded and will not be shared. Those stay with you all as you kind of discuss those conversations with one another. Great, and I'll hand it over to Marley.
Great, thanks, Anna. So I want to take a moment to acknowledge that this second virtual convening is taking place throughout the unceded territory of California, which is home to nearly 200 tribal nations. And as we begin this event, we want to acknowledge and honor the original inhabitants of our various regions. I also want to take a moment to acknowledge my own tribal people as an enrolled member of the Lumbee Indian tribe of North Carolina. But as a woman, a mixed race Indigenous woman who currently works virtually from San Diego on the unceded territory of the Kumeyaay Nation. I also want us to take a moment. I've put a resource in the chat for those of you that want, many of you are familiar with this practice and probably already have identified the territory on which you work or live or sit. But I've put a resource in the chat for those of you who would like to dive a little deeper. But I also have noticed that a lot of us have embraced this practice. I've been in a lot of convenings and spaces where you all have integrated land acknowledgements into your internal or external practices. And I think that's wonderful as a regional practice. And as we're building on this practice as a region, I want us to also challenge ourselves to go beyond just land acknowledgements and ask ourselves, what does it mean to actually be better settlers? And I think one could argue that as folks that work for government entities, we are all settlers in some way. So what does it mean to go beyond land acknowledgement? So land acknowledgements without explicit calls to action or next steps can sometimes feel hollow. I know a lot of you have uplifted that in places and spaces where I have been. And so there are a lot of resources for how we can actually push our departments and our communities in these spaces to create an action plan. And I think we can think about this individually. So what are your individual time, money, resources, even land that you might be committing to local Indigenous movements, local Indigenous businesses? And then as an organization, have you done a resource scan about how your organization can support your local Native Indigenous movements? And then, have a conversation. So we have posted a resource in the webpage under this session around going beyond land acknowledgements. We would love if you as a change team could take that back and think about how can we start to connect our public land acknowledgement practices to an action plan. And so as we move through today, we will have a lot of great resources and we will always be sharing that on the collaborative webpage. And if you're not familiar with the collaborative webpage, we'll continue to post that resource in the chat as well. Great. So just a really brief refresher. It probably feels like a long time ago since we all met in November and there's a pandemic happening. So we want to give you a quick refresher if you're sitting here thinking, I cannot remember what we talked about last time. So our last session together was a wonderful session focused on building our institutional capacity to advance health equity and racial justice. We started to develop some of our shared language and terminology. And we also discussed strategies and approaches for all of you to build your own departmental capacity to advance equity, leveraging your new equity staff. And many of you are also launching new equity offices. And we were joined by 3 fantastic national leaders in this work from Santa Clara County, the city of Louisville, and our very own Los Angeles Department of Public Health, who all shared strategies and resources for building internal capacity. And once again, all of those resources, slides, recordings are available on our session 1 webpage. Next slide, please.
Great. So thanks for that refresher, Marley. So what can you all expect for today? Well, during our relatively short time together, we want to spend a moment to continue developing our shared regional language and to dive deeper into the impact of structural racism on our health outcomes. And we're also going to spend some time going over what this means for your work and getting an opportunity to hear from you all. Now, 3.5 hours is a limited time in the grand scheme of this lifelong learning process. And today, we're really only going to just start to see the tip of the iceberg or scratching the surface of this work. And so we hope that you will be inspired from today to continue learning beyond what we're going to be sharing with you all.
So what is bringing us to this current moment, to this current theme, right? We're sitting here today to discuss a huge issue, maybe the most critical issue of our time, which is addressing racism and its impacts on our health. And really, I want us to all sit in this moment and the urgency of taking action now. We know that the dual crisis of COVID-19 and the murders of Black men and women and across of our country, specifically the murders of George Floyd, Breonna Taylor, and Ahmaud Arbery, led to a national reckoning on racial justice and the importance of acknowledging the impact of racism on our health outcomes. Cities, counties, and states boldly declared racism a public health crisis, and you're all seeing our very own jurisdictions across Southern California who all committed to actions and action steps around addressing racism as a public health crisis. So we have a bold commitment here in Southern California, and we know you all are committed to taking action around this issue. And so with that in mind, we have actually invited one of our very own Southern California health and racial equity leaders. And I feel so fortunate to have her in our Public Health Alliance member family, Dr. Marcia Penny, to help ground us today in the importance of this work and the critical role for all of you as equity leaders in your health departments in addressing the impact of racism on health outcomes. So I want to briefly introduce Dr. Penny, who is the Deputy Director of Public Health for the County of Riverside Public Health Department. And she has 20 years of experience in community and public health. Dr. Penny is also a clinical professor of public health and former chair for the Department of Public Health Sciences at California Baptist University. She earned her doctorate in public health from Loma Linda University and her master's in epidemiology from San Diego State. And I'm just so fortunate that Dr. Penny has offered to open with some grounding remarks for all of us today. So welcome, Dr. Penny, and I'll hand it over to you.
Wonderful. Thank you so much. It's such an honor and a pleasure to be here with all of you. And I want to see, do I have an opportunity to share a slide or two with you guys today? Is that okay? All right.
Yes, absolutely. I believe we'll be making you a co-host and you should be able to share.
Great. Thank you so much for that. So while we're doing that, I want to also thank the Public Health Alliance for the special space that they've provided us with to be able to share. Okay, so here we go. Are you guys able to see that okay? All right, wonderful. All right, so, but again, I want to thank the Public Health Alliance, the Southern California Public Health Alliance, for this special space that we get to share with each other today. You know, the Alliance serves as not only a convener, but they're much like the rest of us. They like to teach and learn at the same time. And so it's wonderful to be able to do that and grow and learn in this space provided to us by the Southern California Public Health Alliance. So today we're living in a great moment. And so I just want to highlight a few things of where we are today as described briefly. Marley opened with describing kind of the reckoning, right? So we're still in the midst of a COVID-19 pandemic, while at the same time experiencing a recent racial reckoning. And that really has highlighted the need for social change. We know that there is a need for social change, but now everybody knows, there's no question, right? And so it's really brought some of the things that many of us in our space and working in public health, working with community-based organizations, faith-based organizations alike, have really seen as the problem and the inequity. And so now that's brought more so to the forefront. COVID-19 has unevenly sickened and taken the lives of residents and members of our communities. And it's also highlighted the fact that health equity is still not a reality for us at this time. We also recognize that both racism and discrimination are important health crises, and that they're consistently demonstrated as factors that contribute to the unequal outcomes of distribution, the unequal distribution of resources, both wealth, all of these factors that contribute greatly to these negative outcomes that we're seeing unevenly distributed across our population. And so where that leaves us now is where we are today at a critical point We have a critical time. We're at a grand moment, and it's been a long time coming that we're here in this grand moment. But we don't get to plead ignorance. We don't get to say, well, we've done our part, and so there's nothing else that we can do, and we're not quite sure what our next steps need to be, because we do know. We've started acting, but we're also put on notice. Many of us have made these declarations, both county, cities, universities have also made declarations around racism being a public health crisis, around social and health inequities that exist. And so we're all now at this forefront. We're at this great point. We've started a lot of great work, but that work needs to serve as a launch pad for what's next. And so we have to think really clearly about, where do we go from here? What are the next things that we can do? Is our declaration enough? No, it's the now what and the so what around this great work. So making the declaration, I know it feels like it took a lot of effort to get there, and it absolutely did. I'm sure for every single one of you, our county included, it wasn't something that happened overnight. We've been doing this work for 10, 15 years, and it took us to this point to actually be able to make those declarations. But now what we have to do is act on those declarations with our partnerships, with our organizations, and really make these things actionable. So that's really thinking about how we strategize and how we visionize the next steps. So we talk a lot about the upstream approach, moving from that traditional medical model, which is the downstream approach, to the more upstream or social ecological model. And so when I think of upstream approaches, think about a swimmer, right? The hard work of swimming upstream. That's what we have to do at this point. We have to move upstream, but it's not as simple as just movement. If you think about a swimmer, it's going to be hard work. It's hard, it's taxing, it's exhausting, and it's painful. And that's where we need to be, and that's where we are, and we're going to be continuing to move in that direction as we try to move upstream. So this also means, if you think about upstream approaches, stepping outside of our organizations. We have to now step outside of our organizations and move to partnering with groups and organizations that exist in that upstream. So businesses and corporations, partnering with our schools, partnering with our CBOs and community-based organizations. And all of that partnering and that work needs to happen around advocacy. How do we advocate for legislative change or policy change? Because many of the practices that we engage in are institutionalized, and we have to change those practices, but we change them through the advocacy, through changes in legislation. That really, the reality is that's how we change. Oftentimes we have to be forced to change, forced to do so through legislative action. And so we really need to engage our partners in a very different way than we have before, and look at who those upstream partners are. Instead of just saying we need to move upstream, we need to sit and really strategize around who the upstream partners are that we need to engage with. So where are we headed? We need to strive for what Dr. David Williams calls a new kind of herd immunity. So this was interesting to hear him describe and read a little bit about what he means when he says a new kind of herd immunity. Resistance to the spread of poor health by immunizing all of us equally against negative social determinants. That's the new kind of herd immunity. We talk a lot right now about herd immunity because of COVID, but think about a new kind of herd immunity that really leads us to a place of health equity and full equality for everybody, for all of our social experiences. So the road that we have to take is not going to be straight, as in this image, it looks more straight than what our reality is. There's going to be lots of twists, bends, and curves, but something to think about when you picture kind of the road ahead. Often on our roads, we have stop signs, and those are our checkpoints. And that's what we need to use to stop. We need to celebrate the small achievements that we make throughout this process, and then regroup and decide on what the next strategy needs to be so that we can make it on the next leg in the road. And that's what we have to do as we look upstream. So I am so excited to be here this afternoon and to learn more from these great speakers that we have aligned today, and to engage with all of you as best as we can and partner to ensure that we reach a point of racial and health and social equity across not only our counties and our states, but across our nation. Thank you so much for this time.
Thank you so much, Dr. Penny. And I see a couple of applause reactions in our squares. I really appreciate your words. I feel like they're just so, they're striking the right chord, I think, with where we are and where we need to go. And I'm going to pull up my slides here. And, you know, one thing that really stuck with me with what you were saying was, you know, this new kind of herd immunity and the need to immunize against negative social determinants of health. That's really the work that we are all really familiar with. And I think that that is something that, you know, we need to take a new frame and a new nuance to get to a place of, you know, enduring health equity. And, you know, we know that we're not there yet. We know that we still have a lot of work to go. The road is long, and we've seen it exposed, you know, very exacerbated through the COVID-19 pandemic. And so many of you will be very familiar with this slide from our last presentation. And there's two things I want to note from this slide. You know, there's one statistic that has changed, and there are several other statistics that haven't. And very sadly, the statistic that has changed is the fact that we have now lost over 900,000 lives to COVID-19 nationally. And sadly, the other statistics that have not changed is around the fact that Indigenous Americans, Latinx, Pacific Islander, and Black Americans are still more likely to die from COVID than their white counterparts. You know, these outcomes are the result of our deeply rooted inequities in our structures and systems. And this comes from our inequities in healthcare access, to housing stability, to economic security and workplace protections. You know, we can continue the list going on and on. And we also know that this is not something new, that for a long time, people of color in the United States have experienced significant and persistent health inequities. And we see this in how Hispanic women contract cervical cancer at twice the rate of white women. We've seen this in how Black women are less likely to be diagnosed with breast cancer, but have higher incidences of mortality than white women. Again and again in the asthma and the prevalence among Black and Native American communities, and, you know, in American Indian and Alaska Native adults, and how they are 60% more likely to have a stroke than their white counterparts. Therefore, we know that we cannot truly eliminate these health inequities that we're seeing without taking a closer look at the root causes behind these inequities. So we pose this question, and we'll explore it a little more. Is an understanding of social determinants sufficient without an understanding of structural racism? Many of us are already familiar and have a deep foundational understanding of the social determinants of health and how they play a lead role in determining our health outcomes. However, the research has consistently shown us that we cannot really understand the full impact of that these social determinants play on inequities in our health outcomes without really fully grasping and understanding the root causes that are driving those inequities, and a deep understanding of what lies at the very root of those inequities, which is structural racism.
So we know, you all know, you've lived through it, you've worked through it. We all know that health inequities, that there are racial inequities in our health outcomes across nearly every major measure of health status that we have. And a lot of folks are being asked, right? You all are your change team leads, your equity leads. You're being asked to explain, why is this the case, right? Why do we see these inequities by race and by place in all of our communities across Southern California? And so I think it is important to take a step back and actually develop a shared regional understanding, right, of why we're seeing these inequities. And so we're going to engage in a quick breakdown of really what does this mean in an effort to really start to build our regional capacity to advance this work. So I think it's important to ask ourselves, when we talk about race and racial inequities, what is race, right? What are we even talking about? Well, the concept of race is actually really difficult to define, which is why a lot of folks feel uncomfortable when they talk about race, right? We've all been there. We know that first off, the genetic studies conclusively demonstrate that race is not a biologic or genetic construct. There is no biologic basis for the concept of race. Many of you know that. And even when it comes to health conditions that we often associate with a certain race, like sickle cell anemia, we actually know that geography, not race, is the basis of the condition. And What's even more insidious is that we know that race is actually a social construct created largely as a means to justify racial hierarchy here in the US using pseudoscience methods like the one you see on your screen, like skull theory. And we could dive really deep into this, and I encourage you all to actually watch the documentary from PBS, Race, the Power of Illusion, where you'll get even more content and information, and that's also shared on our collaborative webpage. But the point here is that despite the fact that race is a construct, our conception of race is very real, and it permeates our health system and our health outcomes. And so it leads us to ask this very important question. If race is not based on biology or genetics, why do we consistently see some of our worst health inequities based on race? And more importantly, what can we do to address the very real impacts of race and racism on the health outcomes of the communities that we serve? Next slide, please, Anna. The research is consistently pointing to racism at the individual, institutional, and systemic or structural levels as the root cause of our health inequities. We know that racism, not race, is what drives inequities in our health outcomes. And in fact, there is a body of emerging research that shows us that toxic stress as a result of racism and discrimination on a regular basis, even small instances of mistreatment, can lead to actual physical wear and tear on our bodies over time. And this wear and tear can actually be passed down through generations through shared generational trauma. Next slide, please.
And, you know, we're talking about racism, and it's really important to begin to establish a shared regional understanding of what we mean when we're talking about racism. We're talking about the effects and the impacts, but it's important to have a shared language around these concepts as well. So what do we mean when we're talking about racism? When we talk about racism, we really like to elevate Dr. Comrade Jones's framework, where she emphasizes that racism is a system of power. It is a system of power and not an individual set of actions. It is a system of structuring opportunity and assigning value based on the social interpretation of how one looks or their so-called race that dates back over centuries of intentional policy and practice choices. And because the system of racism disadvantages some, but also unfairly advantages others, it impacts our society as a whole, sapping the strength of our whole society through the waste of human resources. And one really stark data point that's a reminder of this is that the United States actually ranks 43rd in life expectancy, despite being one of the most well-resourced countries in the world. Now, we know that racism operates on several different levels. And you'll see on the screen, we have personal and internalized, interpersonal, institutional, and structural. And most people may be familiar with the first two levels. But we know when it comes to our community level health outcomes, racism is not always conscious or intentional. Often it is institutional or structural, that is built into institutions, systems, laws, policies, and pervasive deep-rooted practices, beliefs, and attitudes that produce and perpetuate this unfair treatment. We also know that institutional and structural racism often operate in a way that is harder to see and can be much harder to identify. But if we truly hope to address racism as root causes, we need to focus our lens on the institutional and structural racism, which are playing the biggest roles in driving inequities in our health. Now, we're going to dive a little bit deeper into the levels of racism that we showed here, because we want to be able to give you all the tools to be able to discuss and identify with your colleagues in your work when you're talking about the different levels of racism. So I'll talk a little bit about the personal, internalized, and the interpersonal, which are the most, usually the easiest to identify. So personal or internalized racism is the private beliefs, prejudices, and ideas that individuals have about the superiority of white people and the inferiority of people of color. Among people of color, this can manifest as internalized oppression, which is when members of a group that experience discrimination accept and incorporate into their own thinking these negative attitudes, beliefs, and stereotypes about their own group. This can result in lower self-esteem, which can affect health by increasing the risk of unhealthy behaviors, and it may also have even more direct impacts on mental health as well. Interpersonal racism, which is likely the one that we can all immediately identify, is racially discriminatory actions perpetrated by one or more individuals against one or more other individuals, whether consciously or intentionally discriminatory. And this looks like things that we may be sadly familiar with, like racial slurs or offensive jokes. And when acts of interpersonal racism are not isolated, but in fact become more widespread and repeated, they are established practice because they are manifestations of systemic racism. So I want to also, ask if you all can name a few examples of, what does it mean when we're talking about personalized or internalized racism? Also, what are some examples that you can think of interpersonal racism as well? Feel free to drop those in the chat as we're going through these next couple examples as well.
Thanks, Anna. So these next two levels of racism, and we're breaking these down because we know you're being asked to talk about this in your departments, right? And so we want you to have the content and we want you to have a deep understanding, and we want us to have sort of a shared understanding of what this means. And these next two levels of racism, as Anna said, they're harder to see, they're harder to identify and define, but they are the root of what's driving a lot of our community-based inequities. And so when we talk about institutional racism, as Dr. Penny pointed to, we're actually talking about policies and practices within and across institutions that produce outcomes, whether intentionally or not. So I'm going to repeat that, right? Because no one in this space is intentionally racist, but we often operate in institutions or systems that are perpetuating racist practices. So it doesn't need to be intentional, but these policies or practices continue to favor one racial group or put another racial group at a disadvantage. And institutional racism is sometimes used interchangeably with systemic or structural racism, which is why this can get a bit confusing. But when we think about institutional racism, I want us to think specifically about racism within the policies or practices of individual institutions, rather than systemic racism, which is more broad. So I think that can help us kind of break this down. And sometimes we can see these practices and they can be really subtle, right? It can happen in our hiring practices where maybe we're asking for certain requirements that are actually unfairly disadvantaging a certain racial group over another, or it can happen in our banking practices where maybe we, obviously there were more explicit forms of banking practices that were perpetuating racism, but sometimes these things can be subtle and they can relate the way that we're asking for credit or other references, right, in the homeownership process. So when we think about institutional racism, think about our institutions, our policies and practices within our institutions. And if y'all have examples, there's a couple up here, right? Folks could pop those in the chat. That would be great. Anna, you were talking about credit scores. The one that I'm really familiar with is the school to prison pipeline, right? Where we know that Black and Latinx and Indigenous children are often disciplined at higher rates than their white peers for the same behaviors. Or in our criminal justice system, where we know that Black, Latinx, and Indigenous men and women are often arrested or sentenced at different rates than their white peers for the same crimes, right? And I'm seeing Tiffany. I love when the chat's lighting up because I know y'all are engaging with us. Thank you, Tiffany. I see background checks. Absolutely, right? We know that there's a ban the box movement, but it'd be great to even move beyond that because that's certainly a limiting practice. Tim's pointing to redlining. That's much deeper. And hopefully we'll have time to go into a little bit of redlining today. Thanks, Tim. That's a deep practice that is perpetuating racism. And actually, I would say is even creating a lot of the systemic and structural racism we see. Other folks, other institutional racism practices, you're thinking about examples, please pop them in the chat. Next slide, please, Anna. Mortgages, Sonia. Yeah, absolutely. There's a lot packed into housing, and we'll talk about that a little bit more deeply. So when we're talking about systemic or structural racism, right? And we've been talking about this, addressing structural racism as a public health crisis. This is really the system in which policies and institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequities. And when we think about structural and systemic racism, we're really talking the dimensions of our history and culture. And this really dates back to the, founding of our nation for centuries that have allowed privileges associated with whiteness, even the very construction of race as a sort of racial hierarchy, right? And disadvantages that are associated with color. And this really has endured and adapted over time. And it's really important to note that structural racism is not something that a few people or a few institutions choose to practice, but it's an actual feature of the social, economic, and political system in which we all exist. Systemic and structural racism are often used interchangeably, and we're going to use them interchangeably here. I often say systemic, and some other folks say structural. There is a very small emphasis that is a little bit different between the two terms, and I'm going to offer it to you so that you can also decide what you want to speak about. So systemic racism really emphasizes the involvement of whole systems. So think of our whole legal system, our whole healthcare system. And this includes the structures that really undergird that system. Whereas structural racism really emphasizes the role of structures, like Dr. Petty was pointing to, the laws and the policies that are really creating those systems. Because systems also include structures, we're going to use systemic racism moving forward to sort of speak about this system of racism in which we are all living and operating. And Tim wrote Redlining, which is absolutely a historical policy and practice that is perpetuating and creating a system of racism that we see in all of our communities. Other examples, if folks want to pop in the chat, I know a lot of you work in this space and would love to see Dr. Chow's writing about the fact that this is a global issue. Yeah, absolutely. It is a global issue. And some of it has actually been a global issue that we have transported to the rest of the world. So next slide, please, Anna. So I borrowed this from the Robert Wood Johnson Foundation, and I really love it. It is the Racism Iceberg. So if we take a moment to look at this visual, I think it's really powerful because it shows us that systemic racism is actually the hidden deadly base of the iceberg. Many instances of racism are overt, right? So their harm can be easily seen and identified as unjust. We've seen an absolute increase in overt racist hate crimes against AAPI folks and Black folks during this pandemic. And those are racism, instances of racism that we can see. And so they really exist above the water of the iceberg. Systemic racism is often invisible to those folks who are not its victims. So what this means is that when injustice can't be seen by those folks who are privileged because of the color of their skin, it can be more easily ignored, and that allows it to persist, which produces enduring harm, including damage to our health, right? And so that is why we are in the situation that we are in now. And so I really love this image. I think it's really powerful, and I encourage you to take it back to your teams and dive a little bit more deeply into this image of this iceberg and the fact that if we don't dive deeper below the surface, we're not going to be able to correct this problem. Next slide, please, Anna. So why are we talking about this today, right? We're all government folks. You all work in health departments that are situated in government. And it's important to acknowledge that from the beginning of the formation of the United States, government has played an instrumental role in creating and maintaining racial inequities. And this has happened through decisions about who could be citizens, right? Not everyone could be a citizen. In the beginning, it was just white men. And that lasted for a long time, to who could vote, to who could own property, to who was property, where folks could live. And government at all levels have influenced distribution of advantage and disadvantage in American society. And early on in US history, these rights were defined by whiteness. And this has actually persisted all the way through really the Civil Rights Act. And even now we see contemporary manifestations of these practices. So as we focus on our local government entities and how we can work to advance racial equity, it is critical to know our own history. We won't be able to conduct a full deep dive today, but as local government folks, I encourage you to understand the history of your own national, state, and local policies and practices that have created and maintained these deeply rooted inequities. And I also challenge us all to dive deeper into the educational resources that are available on our collaborative webpage. We've provided these under cross-cutting resources in order to build your departmental capacity around this history, but also go back to your local community members and have conversations about your own local histories, right? Because not everybody's history looks the same, even in Southern California. It's important to understand our own local histories. And I'm going to give you an example of one of our members of our own alliance membership, one of our own jurisdiction who has done this. And many of you may have done this as well. So please do share other examples. But the city of Long Beach actually conducted a local government deep dive into their own equity history. And they created, the Office of Equity created this history timeline. And I want to share it with you all because I think it's a great example of an actual task that you all can engage in around a practice of doing a historical deep dive and advancing racial equity. Next slide, please, Anna. So I want to take a moment and we'll move through this a little bit quickly. We just have a few more slides until we do a quick breakout to dive a little deeper. But I just want to give you a brief example about how a governmental policy or practice has contributed to the structural racism we see today, right? Because a lot of times people say, well, that was a long time ago and that doesn't happen anymore. We have all these laws that prohibit, racist policies and practices. So let's just take one small example. How many folks with me today are familiar with redlining? Thumbs up or thumbs down? And don't be shy if you're not. I see some hands being raised, some thumbs up. Okay, great. So redlining refers to the federal government's practice in the 1930s of raiding neighborhoods to help mortgage lenders determine which area of the city were considered risky. The actual federal government, the Federal Homeowners Loan Corporation, created these color-coded maps, and many of you may have seen them, and if you haven't, we'll put a resource in the chat called Mapping Inequality, and you can look at the maps for yourselves. But essentially, this was a government-sanctioned practice that allowed the government to say that areas that were predominantly white were separated from areas with people of color and were given the actual designation of green. And a green area meant that those homes were often deed restricted, which means they could not be sold to a person of color in order to keep the area predominantly white. And that those areas were deemed really great for lending, right? These were areas that you want to give money to, you want to give folks the loans in order to buy their homes. And then in areas where there were more people of color, these areas were given red distinctions, which means they were not safe for loans, they were not safe for lending. And this practice, along with other segregationist housing policies at the time, had lasting effects. And we'll talk about that in a moment. Anna, next slide, please. But I just want to show you these maps because if y'all haven't actually taken a look at these maps, and you'll have to pull up the next animation, Anna. It's really powerful how explicit the racism was in this federally sanctioned practice, right? And so I like to show this because you can see here an actual description of the documents in the Watts neighborhood in Los Angeles. And you can see that they actually describe that the Watts neighborhood contains one of the largest concentrations of Black people in Los Angeles County. And they point to, because we're in California, other folks of color like Mexican folks and Japanese folks. And then they talk about substandard constructions like shacks. And they actually use a racial composition of the Watts neighborhood to justify giving this area a red distinction. And if you go to the next slide, Anna, and one more animation, you can see how this is different from an area that was designated as green at the time. And this is Bixby Knolls. Many of you know Bixby Knolls. This is the city of Long Beach. This area was actually celebrated as being deed restricted. And remember, that means you cannot sell homes to folks of color. And that the location and design allows for racial protection in perpetuity. So this was considered a green area because not only was it mostly white, but this neighborhood had made sure that only white people could live there in perpetuity. And so this was given a green distinction. Next slide, please, Anna. So why is this important? Well, the 20 plus years following the Great Depression, the American economy grew tremendously. So if you were unable to maintain or access a mortgage prior to this boom, the wealth growth through increases in home value is hindered. And this has been the largest contributor to the incredible racial wealth gap in the United States that we see today, in which Black families and Latinx families on average own about 1/10 as much value in assets as non-Hispanic white families do. Most Americans still hold the majority of their wealth in home equity, and the growth in homeownership during this period allowed for one of the greatest generational wealth transfers in history. But the effects of redlining are not just seen in differences from home ownership, because we also see how with COVID-19 outcomes, how race and place are intimately connected. Because if you were deemed as an area that was not safe for home loans, you were also an area that discouraged businesses like banks and supermarkets from opening in your community. Because why would you want to invest in an area that the government said was not safe for lending? And as a result, many people of color were pushed further into segregated communities with less resources, less wealth, and less community investment. And these are all driving factors, right? The social health behind the differences in the health outcomes we see in our communities today. And in fact, a recent study that was just published showed how the residents of formerly redlined neighborhoods are at increased risks of health issues like preterm birth, cancer, and maternal depression. So a policy, one policy, right, governmental policy like redlining, the effects of that can still be seen in nearly every system we have today, and it plays a big role in our health outcomes, especially our community-based health outcomes. Anna, next slide. And so as we close this and we break into small groups to dive a little bit deeper, I just want to take a moment to think about the role of government in addressing structural racism and how this really impacts all of you. And Anna, I'll hand it to you.
Thanks, Marley. These current inequities continue to manifest in our institutions and systems that create barriers for certain communities and government decisions, policies, practices, and processes, as Marley mentioned. And as government staff, we must acknowledge and understand these historical and current root causes of the inequities and institutional and systemic barriers. We also have to acknowledge that these inequities have been created and maintained by people with really good intentions. So if we don't pay attention to the data, if we don't understand the history, if we assume that we are the experts over the community about the things that they need, then we will inevitably continue to be a part of creating these systemic barriers to health equity.
So this is, I'm calling the undeclared crisis, I admit, because the crisisness of health equity that arrived with COVID, I initially found pretty annoying. I've recognized it as an opportunity now, but things happening like they always happen and being discovered was a little hard on us who've been railing about this for a long time. So it was the undeclared crisis that really isn't new, and we all know that. Next slide. Oh, I will give my disclaimer. I have a lot of opinions. They are my opinions. They are not the opinions of the Department of Public Health or the City and County of San Francisco. I will tell you a lot about our work, but we're a sunshineable public institution, so none of it is proprietary. You can contact me after if there's anything you want to hear more about or any documents you want to see. Okay, so our Health Commission, a few months into the COVID pandemic, made this declaration. It actually follows a lot of equity work rather than preceded it. And it was in fact a joint resolution with the Human Rights Commission, which inside of it contains the Office of Racial Equity. So it bore out of some very specific work on COVID that the equity officer in our emergency operations center structure, and we did have one from day one, was from the Human Rights Commission, and she wanted to have a news conference or something about how racism was impacting COVID. And I, with my general annoyance on that, said, well, it's been impacting everything forever. And lots of people who aren't into health weren't necessarily 100% aware of that. And so she worked with some DPH staff to turn that not into a press announcement, which we did, but into something that was a little bit, I hope, more lasting. Our Health Commission strives to attach specific commitments to resolutions, usually and a year later, we're going to check on this kind of language. And this one had some specific commitments that were worked out between the two commissions. Many of them were things we were already doing, but were asked for. So funding for the Office of Health Equity, it existed. I appreciated the thought of funding me more. All staff would get equity training. That was actually already happening. Establishing measurable equity goals. Again, we were probably in year 3 of filing equity plans. Review of all existing policies. I strive to understand how to prioritize which policies to look at, because all existing policies is a really big thing, but we absolutely are focused on policy. Establish new anti-racist policies, and it is both. There are lots of old things we need to get rid of, but lots of things that are missing. Use an equity lens to develop RFPs. Funding is a central issue in our communities. The way we fund, who we fund, how they get a say in funding. There are lots of things that we care about, and they care about other things too, but that funding issue becomes a crux of many conversations. Equity criteria for all contractors. There are 2 sides to that. 1, they want to be funded more equitably, but 2, we and many in the community want more accountability with that funding. So what is the criteria for their performance and impact on equity? Disaggregating all of our data, mostly happening, and including sexual orientation, gender identity in that. Improving the experience of Black staff. Again, an incredibly hard issue that sits in the middle of a lot of other priorities and can be a barrier to those priorities in many ways. And I'm not sure when we'll ever declare that done, but we are definitely working on it. And then reviewing this plan twice a year. It actually ended up 4 times a year, but we review it definitely that twice a year. Next slide. The reason I point that out is because I think the resolution had a little bit of a unique place in our county. It wasn't as much about making a statement internally. We had already been doing this work. It worked really well, though, to alert our partners to their role. So trying to frame things in that way that put equity first, was about health equity, was easier once we had talked about the COVID model as one that explained much of what was happening and how that related to other equity issues that people have been working on. So it sort of pushed to a health in all policies kind of framework that we hadn't otherwise been able to have. Where we had been at the time that was done, I think was certainly not at a super mature period, but we had been doing some work for multiple years. In 2014, we started a Black African American Health Initiative. In 2018, I wrote a report that was kind of the coming out party of that initiative, showing all the health inequities that we were trying to deal with and many that we hadn't dealt with and that I was inviting the community to help with. That took years for people to actually read and respond to, but it was very nice to have that already existing by the time COVID came. Expecting Justice is a doula and other perinatal health program meant to fix health inequities for Black and Pacific Islander moms, which are 2 populations that are suffering the most in that area. We had already established the Office of Health Equity about a year before, and that was consolidating work where that was already happening. And then lastly, at the very start of COVID, and I took this graph from May of 2020 out of my old emails, but we had already seen the difference in impact because we were already disaggregating from the beginning. By that point, we were already geolocating by neighborhood. So that was partly why people wanted this declaration, because we talked about it from the beginning and started working with our Latinx community from the beginning. They got activated and demanded much, much more. God bless them. But we were there in the beginning, at least understanding that it was going to be an issue. Next slide. So I'm going to give you that journey a little bit, partly to explain the framework we're using, but not actually being in complete fidelity to. So I'm not sure if who in the group are members of the GARE Alliance, so the Government Alliance on Race and Equity. Many folks in California. Actually, that ghost thing behind there is all the different GARE jurisdictions in California. There are quite a few of them. We in San Francisco signed on to that family, I think in about 2014, might have been 2015. And representatives from every city department were required to go. We also went, and it created a shared framework across the city that we jumped into. Their framework is a lot of things, but one of them is this 3-step way of looking at things: normalizing, organizing, operationalizing. And those mean what you think they mean. Normalize, make the conversation normal, have this be an issue that's part of daily work. Organizing, having an infrastructure and data and tools in place to actually do the work. And then operationalizing, actually moving forward to change the way you do things and actually try to achieve outcomes. The way we did that didn't actually follow that, partly because we ended up in GARE, I think a year or two after we'd already started the work. So we were doing leadership training to start. We have a department of 8,000 people. We had trained 700 managers and executive leaders over the first 4 years of this project, 3 years of this project. So we had done a lot of leadership training. And that was 32 hours in a room with an equity leader telling people's life story. So it was a fairly intensive training for that many people, 4 full days, but there was a lot of it. And it actually did have that impact of normalizing it and making us feel like something inevitable that people were going to need to do and learn about. Equity leadership staff, I was hired right around that time. Then we did some data when I came in, data and self-assessments to kind of see where we were. We did some projects. It was mostly project-based in the beginning. I was brought in to run projects, and we over time started to argue that that was not going to do much. And so this became a systemic change. We hired lots of other people slowly, and then had all staff training, and now we're doing some policy and planning. So not a perfect representation of normalize, organize, operationalize, but I think the fact that we didn't do it actually helped prove the need for the framework, because lots of things that we tried to operationalize before normalizing anything with anyone failed miserably. Staff with no malice just sabotaged them because it didn't seem important, or they actually disagreed. Special treatment was talked about a lot. So those basic issues that you need to clear the air of, and having staff to do the work, both proved to be really important. And a lot of things we tried early without either of those elements failed, and failed painfully. So I would really suggest that if you are not starting already, that you really try to use that framework, because I did find it really helpful. Next slide. So this is the approach that we're using. What all the colors did that for, that's okay. The Office of Health Equity is a lot of things, and we do a slowly evolving collection of things, because I was a department of 1, and then we were 3, and then we were 5. I think we're now back to 3 because we've had so many deployments and great resignations. And then by next year, or a year and a half from now, it should be 11. So it's been a little bit waxing and waning in terms of our capacity. So I have a framework, and we've done all parts of it, but not with the same intensity as one thing or another came up. So the first is absolutely culture. It's normalizing, but it's more than normalizing in my mind. Normalizing really talks a lot about the conversation and things that people are willing and able to talk about. It's sort of moving that Overton window that says, what's a normal conversation? So I always tell people, check your blood pressure and your heart rate. If they're up, then you're not quite done yet learning about this, because you should be able to just have a conversation at work. But it's also the way people treat each other. So I put the respectful workplace policy in that group. I put our messages to patients in that group. I put the involvement of other departments in that group. So sort of the way in which people are going about their work and think things are important. Capacity is very much staff. There's absolutely a budget there. There are data systems, many things needed to be in place, but staff was the underside of all of those things. So that was really important. And in fact, I would say we spent the last 18 months focused almost entirely on that. Health outcomes. I always tell everybody, if we don't do something people can feel, this is not going to last. So these are burning problems for people. They are incredibly painful for some of them. And so to see work happening and not have an impact on them, it's just, you will lose support. We have at times, in fact, all of that capacity building was really hard for people to sit through, but it was just impossible not to do it. But we have to have some outcomes. The wins really matter for folks. And so keeping health outcomes as a separate issue that we are dealing with, many people would assume it was the primary one, but it actually takes some work to keep it there. The community has issues that are not health. Staff have issues that are not health. And it seems inevitable that health differences exist. So it's very hard to convince people of differences in life expectancy as a fixable problem. It's not something we're going to fix tomorrow. And so getting that as a solid thing that we are looking for outcomes in has been a really important part. Community engagement. You really can't have equity from a hierarchical position. You can't really have equity telling people what you're going to do. And it's not even about good manners, although I think respect's important. In my mind, it's about our segregated past and present. Most people do not have enough in-depth knowledge about the lives of other people in totally other communities to be able to make decisions for them. 10 years ago, it was something like 80% of white people on Facebook had no non-white friends. Now it's down to like 50%, but that is not a basis of knowledge. So whenever somebody tells me that wasn't racism, I'm like, are you sure you would know? How many experiences do you have? Most people don't know things that they've never experienced. It's just not a way in which we gain knowledge. So you can't really talk for communities because you don't know them that well. Even if you lived in them, you don't know them that well. So, and the very last piece is accountability. None of it matters if somebody's not held accountable for it. And people say that a lot. I have to say, I'm kind of tired of hearing it, I admit, but I mean accountability in reality. So having people have a very set plan, having incredibly specific outcomes if I can get them, and then having a moment on the calendar preset where you're going to stand up and say whether you succeeded or failed. That kind of rigor is a cultural thing. So some parts of my department have that system. It's essentially a very hierarchical healthcare kind of approach in some ways. It is not necessarily a behavioral health approach. It's not necessarily a health education approach. So sometimes I had to put that into the culture and sometimes I had to make the culture work for that. But it is important. If you don't do it, it really didn't work. And then the last is DEI, and I don't have workforce on there as a separate thing. Partly because it's so ever present in people's minds that I really needed them to be able to think about anything else. And also it's part of everything. Who works here defines the culture. The way in which bosses treat their staff defines the culture. And it's also a policy issue among our workforce. Capacity is about DEI. It's about, can I get the people in who are going to gain these skills? All of these things have a workforce part of them. We've all learned that community engagement requires a workforce because many of us didn't have that workforce when it became necessary. So I put it in the middle. I don't always show it because I have audiences of people which I'm trying to convince that there's anything else in the world. But it is really important. And I think it's part of everything. If there isn't somebody, a person, a life, a problem in a person attached to whatever issue you're working on, it probably isn't really a priority because we've got a lot of things that are actually impacting people to work on. Next slide. I'm not going over all of our different things of ways of working, but you can look at that later. So one of the most powerful early things we did I think even more important than the intensive training, which was transformative, but didn't really tell people what to do, was to do assessments. I did lots of surveys in the hospital, in the different parts of the public health department. We did lots of surveys and lots of kinds. So looking at organizational development, we used a set of questions from GARE in different areas. So some did it for their whole staff. Some did it for individual teams. There's a tool from Barhi that's really involved, and we only did a few times, and we took parts from, but both of those matter. And the reason they matter is not just because it's developmental and you can't really move forward if you don't know where you are, though that is a basic pearl in my opinion. The other is that people don't have the same experience, and they don't know that. So we don't talk to each other. So I would have the same question about how are people being respectful or not, or have you experienced this, or do you think we're good at this? And Black staff would say we were terrible. No matter where I asked, Black staff said we were terrible. Asian staff said everything's fine, like literally sometimes scoring a 5 out of 5, which I'm still just stunned by. Latinx staff were kind of close to the bottom, but not quite. And the pattern held everywhere. So we do not share the same experiences of what's happening. So people can understand your solution if they don't actually have any kind of shared understanding of the problem. So we did lots of assessments, and mostly those were just to tell people about themselves. Team dynamics, I've done some things around team dynamics. Mostly that is going to places that are on fire, or if somebody thinks they're going to be on fire. It is very hard to do that across a department of 8,000, but sometimes you need to talk to people about the way they are treating each other. And I found the everyday racism scale incredibly useful for that, partly because people who don't think or experience racism have a very hard time understanding the banality of it, that it's just being treated kind of crappy on a daily basis. So that scale that says, has anybody ever thought, treated you as if you were less honest than other people? You get a whole group of staff who say, yes, it's news to everyone, but then you can explain what made you feel that way. The fact that we have to sign out to say when we've left the office, and then you don't. Those kind of things that feel benign are the framework of most racism right now. So being able to figure out a way to tell people that's what it is when you see that has been really important, because they can't fix it if they don't see it. And then the last is limits and opportunities. So who's getting opportunities, who's being limited, which patients are held to a standard, which ones get the benefit of the doubt, which staff get trainings, which staff get reprimanded. So racism's function is to take whatever it is we have and be able to make sure that the bad part of it can be siphoned off to go to some people, and the good part can be siphoned off to go to other people. The complexity of things means there's almost always a good and bad, and there's always a way to divide it. So education, Christmas bonuses, I mean, everything has a way in which it can be used to play out some racist idea. So getting people to just look at almost anything in their workplace, in their life, in their work, has been able to help people understand that. The last is the staff engagement survey. I adapted 6 questions that GARE uses on their survey. They were not quite what we needed, but we definitely weren't getting what we needed out of the commercially available staff engagement survey. And so I added these questions. I will tell you, Native American and Pacific Islander scores aren't on here because those groups were too small for reliability. And I don't want to show 2 years of data that look crazy. So, but this is one question. I'm actively involved in advancing racial equity in my work. You can see that between 2019 and 2020, still waiting for 2021. Actually, we skipped it because it was too crazy. It's coming in the spring. So those years were big years. And if you look, the biggest gains were from our Black staff, who were the most, I would say, not hesitant, but who were waiting to see if any of this was real before really jumping into it. And that's where they crossed the line, where they decided it was real and decided to jump in. There's a little gain for everybody else. We were waiting for that moment. I was waiting for that moment. And most people are convinced by what's really happening to them and not by what you say. So I have a lot fewer statements about equity than perhaps were recommended or other people have. But I found that the more you talked about it to people who did not feel any change, the more cynical they became about the legitimacy of your effort. So it was actually better not to talk about it in some places and to have things actually to talk about the change that was about to happen, not so much about our values or ideals, because people have been talking about ideals for a long time and doing really very little about it. Next slide. All righty. So in that sort of normalizing frame, we have a bunch of things. I don't have nearly as much as I want. That was partly because the beginning of really the ramp up happened. The Office of Health Equity was established in September, and COVID for San Francisco happened in January. So many things were derailed. Lots of things had one meeting or one episode and then just kind of went on a hiatus. What we were able to maintain and have had for about 5 years is a weekly discussion series. It went very seamlessly from in-person to online. And there are probably a core of a few hundred people who go to that in one way or another. I consider those my early adopters. I look at this as culture change, which means that it is very likely, in my opinion and my experience, to follow the same way all culture change goes, which is they're early adopters. There are people who follow behind them who are kind of easy. There are people who are a little harder to get, and there are people you're never going to get and you're just going to have to mandate later. And so we have some things for early adopters, some things that bring the people along after, and then some mandates. And the mandates are last. So I don't have as many of those as I do opportunities. So we have a weekly discussion series. They do a podcast, a journal, a newspaper article, and then discuss it. It is really just to give people a chance to talk about race in this mixed company and learn a few pearls. Online racism. This is a screen grab from that online training. The creation of race shows that you can go through the census and look at what was considered the races in each census, and it changed a bunch of times. All I want people to understand is that it's a made up thing. So there are many principles in this, but the immutability and reality of race is one of the first things I need to get rid of. And so that's what's in that training. There are lots of other things in there, and the sexual orientation, gender identity, and online racism training serve the exact same purpose, which is to take the utterly clueless person who sucks all the energy out of every other in-person training and make sure they at least knew the basics before they come in the room. So I tell trainers, do not define any of these terms at the training. It is a waste of everyone's time. It makes us not move forward. And it is in fact an unconscious delaying tactic for people who don't want to do it. So you either already know this or you get invited to go back and do the online training you apparently did, but didn't actually pay attention to. Orientation has a culture day. It was 1 day and now it's 2. And trauma-informed systems, sexual orientation, racism, and there's another thing on culture day, I don't remember what, but a whole day of it, just because you don't want people coming into the department further back than the work that you've done to get everybody where they are. So trying to instill people in the department who actually are a little ahead of the people they're joining is one way to pull everybody forward. And then the last is we've done a few of these 28-day self-study challenges where you give people a thing a day to think about. Lots of these are the things I have centrally. There are different things in different areas. So I'll talk about our structure, but different leaders have created different trainings that are specific to behavioral health or environmental health or whatever their needs are. We have a couple different centralized trainings, relationship-centered communication, very much centered on clinical staff in the hospitals. 5 months of health equity fellowship that has a curriculum of, it was meant to be a day a month, and it's impossible to do Zoom for a day, so it's broken up more than that. But basically we do a deep dive into how do you operationalize this for managers. And then equity champions are staff who get some release time every month to learn about equity and then try to pick a project that they can do in their area. So that when I get to the question again of, have you had a chance to actively work on it? I get more and more answers and people feel more and more invested. Next up, next slide. So I struggled for a few years before figuring out that I was going to back up from everything and have to do some infrastructure building. It proved nearly impossible to deal with 2 hospitals, 50 different clinics, a bunch of different health department entities, and have any kind of progress with only a few people. There are places where you really can't do anything unless you're a member of their group. And that has proven true. Also, the cultures of my different groups were quite different. Something that was needed by behavioral health staff was very different than was needed in the hospital. And so they needed to make their own. So I'm the Chief Health Equity Officer. I have 2 managers. Well, I'm supposed to have 2 managers. All of these are theoretical. Lots of deployments and moving. 11 support staff, some of which are still being hired or rehired. And then out in the department, I have 11 equity leads, and some of them have teams. So I sit in the middle. We meet every 2 weeks. Used to be every month, and then COVID happened. Now it's every 2 weeks. And then they come from the different parts of the department with themselves, their teams. The equity leads started out as kind of voluntary positions. They became full-time managers at various times in the department history. The hospitals got theirs first because they have more money than everybody else, then behavioral health, then clinics, then public health services, then admin. And that was in my order of priority for what I thought outcomes would be. There's also an executive group that oversees the work of that group. They meet every other month, and that's every department head in the department, every head of every larger section of the department. I have divisional councils. All of those equity leads have their councils, and there are probably 50 more or more people on those councils. We had the Equity Fellowship had one class before COVID hit, and then we restyled it and did it last year, finishing in December. And there were 33 people, I think, who went through that. I have 130 equity champions, 80 last year, and then 50 this year. People are a little bit scrambled. So that those are the people who have 60 hours a year. So it's meant for more line staff. So those are lots of different people at different levels. And that was very deliberate because what is change, we had a lot of transformational change in leadership that staff felt not at all. They weren't pushing it down to their staff because they didn't know how, and their supervisors weren't pushing it down to the line. And so those people have the ideas. For the most part, that's our more diverse part of the department. And so if we're going to be making a plan for how to deal with inequity and racism, we probably shouldn't do that with a majority white group, most of whom who don't work in the field anymore. It wasn't the most sensible way to go about it. And so I'm looking for ways to bring up staff who are in that world and have a little bit more experience. Next slide. I really care about actual disparity reduction my preferred approach is as quality improvement when that's a thing that the people I'm talking to understand. So communicating that access and equal quality are goals so that the different ways in which we measure access and quality can just be used in service of equity. So look and see, are people getting equal access? Are they getting equal quality? There's a lot of assumption that goes into how people understand those differences. And so getting data actually helps move people past the magical thinking that racism is so good at. So that means data disaggregation needs to be standard. It took me years to convince people of that. People don't like to uncover problems they don't already have a solution to, but the problem's there whether you pay attention to it or not. Gap closure is whatever your standard is, it also needs to be gap closure. So we want to have blood pressure come to this number. Well, you also need to close the gap. So it's just now become an automatic second goal. So that the first goal is not an average. Identifying bias through data. This was not something I pushed, but I think an incredibly brave way in which primary care has used this approach. And that is that they have made a rule or a goal and done PDSAs and then gone down to the level of staff. we're supposed to do blood pressures this way. Great. Did that happen? Did it happen for all race and ethnic groups? And if not, which staff were those? Trying to identify actual moments of bias, because that is where these things happen. They are human interactions. Even if there's a rule, the paper didn't do anything, a person had to act on that. And so looking at who is the actor so that we can pull people in to identify it. Often they found that just telling people it was there was enough to make them aware enough to change their behavior. And so you have an intervention. Did the intervention even happen to everybody in the same way? And if it didn't, can you trace back to when you had that breakdown? And that's proven very effective. The next step from that, which we've only done a few times, is take that expectation of not having any differences and make that part of the performance review. So a few years ago, the nurses having equal blood pressure follow-up, have no racial gap was part of their performance review. So standardization to reduce bias risk. So anytime a human has a choice, they have a chance to make a biased choice. They may also have a chance to make an artistic, lovely, humanistic choice, but you at least have to accept it as a risk point. And so I ask people to mark out where those are, and Lean and Six Sigma and all of those things that do a very good job of logging out what a process is, also are very good at logging out where the choice points are. And those are my risk points. And so standardizing those, monitoring those, looking for what impact they have on the total outcome is one way to approach it. And my little story about that is the graph on the side, the vaccine appointments. So we absolutely looked at vaccine equity when we did COVID, and we looked at, did we have equal uptake? There were lots of reasons we didn't. It was a really good way to get the help of community by being able to say, this is not where we want you, you're behind and we need you to move up. But what that meant internally was that we had to look at what is our role. And our role was to offer people vaccine. And so they were calling and trying to get people to come in. And the reality was, did you make an appointment? And then was the person able to come to the appointment? And so having that as the measure, not just did they get it, and the VAX appointments were both the offer and the success. So you can say, did you want an appointment, and call it an offer. There were differences in offer, like our African-American patients didn't get offered as much in some places. And so that was corrected, whether that's because people believed they would be hesitant, or, I mean, the not being called as much has frankly been true from public health nurses to everyone else. So it wasn't exactly shocking or needed an explanation, but being able to tell people that that is the standard, there isn't an explanation that exists in the person, in the patient, that will be accepted, that you actually have to meet some standard yourself. So all of the things that racism tells us are different between people become irrelevant. I don't care what their reason is, you just have to do your job. Next slide. There's so many chat comments. I never look at chat and speak at the same time. So I'm hoping none of that is meant for me to answer to, but I'm going to trust that Marley or you guys will ask me after. So just so you know, I'm not looking at it.
We will,
So,
and just a quick time check if we're able, just so we have time for the Q&A.
I think this is almost the last one.
Yeah, perfect, great.
Okay. So community engagement is my focus this year. There are lots of ways to do that, just so that everybody, it's not just about having conversations. There's a planning group for Black health disparities. The HIV RFP for services has now been linked to disparity level, determines how much money you get. We did an ethnographic study with patients around heart health, where we had ethnographers follow them around all day. Black family mental health RFP was done with community-led priority setting. So there are lots of different ways to do community engagement. It is not just groups and conversations and focus groups. So trying to keep people limber. Next step. Next slide. I think there were lots of those that came up during COVID. So community liaisons, non-transactional CBO relationships was a really big one. We have lots of relationships with people we give money. Those are incredibly messy relationships, and they're not great at connecting us to community. So there were lots of new things that I'm trying to bring into our normal work, but COVID was a really good lesson in those. Next slide. There's a cycle. I like to formalize things so that people expect them. They can not come and make it up the day before. So there's a plan, there's an assessment, there's a report, there's another report, there's a mid-year report. The mid-year report's actually an oral report in front of the health director. There are lots of things. I want to change people's attribution of where the problem is. Your plan cannot be about changing the patient, and really get them to record wins so that the idea that all of these things are static and immutable can be chipped away by changes that we succeed in making. Next slide. Just some pearls. Community and staff have reasons for doubts, so just succeed, and that'll actually matter more than anything you say. Early adopters are my best resource. I love them. The internal collective impact, getting people to work together, really takes some backbone support, some communication. There really are different groups. And then designated leadership makes it more likely that people participate and to fight for that one. People feel like we don't want equity to just become a thing. It's everybody's job. But you know what? It's everybody's job if you keep telling them that every day. And somebody has to be in charge of saying that. So I think that's the end of it. I knew 15 minutes would be a rush for me. So sorry, that was very fast, but I'm happy to answer questions after. Thank you.
Wonderful. Thank you so much, Dr. Bennett. And I could just see how much there was to share. And so I really appreciate you taking the time to really dive into those topics. And I'm sure that there are definitely some questions that are bubbling up. I know I've seen a few in the chat, so we'll definitely have some time to engage with everyone afterwards in the Q&A. If we didn't mention before, if your questions are coming up or any comments you have, we encourage you to put them into the chat. We'll be combing through and bringing those up afterwards when we have the Q&A portion with our guest speakers. And now I want to invite Dr. Matias Valenzuela from Seattle King County Public Health. Thank you so much for joining us. The floor is yours.
All right, thanks, Anna. And I really enjoyed hearing Dr. Bennett's presentation and lessons and experiences. I think there's a lot of things that resonates and similar to what we have been doing in Seattle King County as well. So, and it's great just to really love how you've created this learning collaborative across different jurisdictions. I think we did a lot of this in the Pacific Northwest. Even, I think Dr. Bennett mentioned GARE. We actually had the precursor of GARE, which a lot of folks who are now at Race Forward were in a regional Northwest collaborative that we created with Portland and Seattle King County. So I think just, working as a region is extremely important. I'm gonna talk a little bit also and kind of infuse history into this as well, especially here at the very beginning, because, I do think some of the jurisdictions that are newer or starting this work in more recent years have a true opportunity to leapfrog and really learn from jurisdictions that have been doing this for longer and use some their learning, such as from GARE or from San Francisco or King County and other places that have been doing this work. And really, it's much more of a field of practice. We actually started in some of the there had been diversity work before I started in 2002 in public health, Seattle King County, but really we had a strong push from employees. About 2002, we had about 200 people go through, including a lot of our leadership, go through an Undoing Institutionalized Racism training with the People's Institute. And I think that was extremely important to begin to create some momentum for us as a county, and as public health in particular. Then we were part of some national groups, including Place Matters in the mid-2000s. So all of that really led to us in 2008 launching Equity and Social Justice as King County with public health as the lead agency. And we were the lead agency for about 7 years until we founded within King County the Exec's office, the Office of Equity and Social Justice, which I directed for 5 years. And then I came back to public health in early 2000, just in time for the pandemic. And then I'm going to feature some things that are historical, that are built into our public health work, into our county work, and then some of the things that we're doing just now as public health too around this. So if we go to the next slide, I want to just show data. This was a lot of our early reports too, were a lot of just by our, what we call them, social determinants of health, but really determinants of equity as we define them in a King County ordinance that we passed in 2010. I think it's extremely important for us as a county that we actually created an ordinance that laid out definitions of equity, definitions of social justice, laid out some systems, and really also made this law in the county, and really put it in more aspirational terms that we had to really embed equity and social justice in our organizational practices, our work with communities, and our policies. And since then, I think we've been really learning to do this. And I think it was very important early on that our executive at the time, Ron Sims, just launched the initiative without necessarily knowing where we would go and where would this all lead to. And I think the progress that has happened has been pretty amazing, and the momentum has continued to grow. If we go to the next slide, you can see the frameworks. I appreciated the GARE framework that was just presented. This has been part of our framework in the county that we really, as we're founded in kind of public health principles, we talk about upstream. And really, one of the models is that and framework is that we have this stream, which is the unhealthy stream, is how we tend to do business. And it's not just in public health or in government, and also a lot of the nonprofit world, those are industries in and of themselves are actually supporting some systems that actually do continue to cause a lot of harm. So you think about this unhealthy stream on the right side of the stream, all the things that are downstream, and this is in this version of the stream is bigger below, because that's where we're putting a lot of our energy and attention around issues like incarceration, obesity, homelessness, really driven by social determinants of equity and social determinants of health, which are those middle conditions when they aren't adequate, they aren't healthy, they're not strong, and really driven by some of these upstream factors that are such as structural racism and different kinds of discrimination and bias. So if we go to the next slide, really what we've been trying to do with King County is actually make a shift of really focusing, instead of focusing downstream, focusing upstream, creating the policies and systems, including racial justice and racial equity. So then we can have these conditions in the middle of the stream. So the social determinants of health and social determinants of equity. So then people then have the outcomes that we want for everybody, really. So I think this has been a driving force. It's a theory that we've continued to refine, and it's great now that the county's equity work is really still founded on these very solid, I think, public health principles, and it's also a major guide for the work that we do within public health. If we go to the next slide, I think this is my office in 2015 for the county when we had with the Office of Equity and Social Justice. We really undertook, we had a lot of experiments and have been doing a lot of work around equity and social justice, but didn't have a clear plan. So I know a lot of folks here are working on these plans, and we, before we put any pen to paper, we went out, we talked to about 800 employees, we talked to over 100 community organizations and really heard from them, and really using the equity principles about lifting the voice of those who've been most marginalized by governments and by institutions. And then we came up with this, I think, very ambitious plan, and our key strategies in the plan were to invest upstream and where needs are greatest, invest in community partnerships. What we heard, for example, in those conversations, just the problems with our funding mechanisms, basically how we tend to use community when we need them, we don't establish relationships. So there are things in the plan that we established there around really expecting departments to actually have community navigator, community liaison programs, and also things around how to fund communities that have less barriers. Also, the idea of investing in employees. It was, of course, very interesting that we begin to disaggregate by race and then also by pay. You begin to see some really significant gaps in terms of the employee experience. We not only held kind of big sessions with employees and heard from equity teams, we actually went to frontline employees, we went to the janitorial staff, we went to people that work in parks maintenance, in our public health clinics, frontline staff there too, and really heard the challenges that employees were having. So what we developed within this plan too is things such as for the lowest paid 20% of pay, that every employee would have a professional development plan, because we found out that a lot of people actually in higher paid positions didn't have professional development plans, but lower paid employees did not have that, that right really. So we've built that in. We also, looking at the data and seeing that we are at least racially diverse in our leadership positions, we created a goal for the top 20% of leadership to racially diversify. So those are a number of different things, and we break in. These strategies are then infused into different goal areas: leadership, operations and services, plans, policies and budgets, workforce, workplace, community partnerships. So there's a lot more there. If we go to the next slide, then of course we have our, we've had different versions of an equity impact review tool. Our original equity impact review tool was about 15 pages. Now it's just 2 pages, and it's that image on the left, which is pretty, the concept is pretty straightforward. I think the practice and implementation can be a lot more challenging. But the key thing that we have tried to do too is, especially around, and COVID is just an example around this, but really trying to make sure that we include this equity impact process and approach to some of the key efforts that we have. So just as some examples around the zero youth detention, we do have a roadmap to zero youth detention, and this is work that's led through the health department. We've really moved from having the juvenile justice really headed by kind of the criminal legal system, and really having a public health approach. And our executive has also put the goal of really closing the youth detention portion of our youth jail by the end of 2025. So there's a roadmap and work that's being done there. There's we also have a county levy, which was really using our equity and social justice kind of theory of change, investing upstream and also investing in kids, and then on those communities that most need investments and support, which is the project in particular is called Communities Opportunity, that have really kind of built. So the reason I just include this is because I think the kind of the bread and butter and the success is actually in being able to really put this into practice in terms of the policies and programs that you're implementing. If we go to the next slide. So this is when, in the midst of the pandemic, our public health director and our King County executive in June 2020 declared racism a public health crisis. And one of the things that we did there too is we had conversations with community early on with our Pandemic and Racism Community Advisory Group and with some other groups, and really started to make some pretty significant shifts in terms of where the county invests in the role of public health as well. And you can just see here some of the things that we, with public health really at the table, it's really important to actually be in these tables, and especially when it's not necessarily public health, seen as public health areas like kind of the things such as law enforcement or incarceration, that we have a public health approach around this. So for example, really, we were able with COVID to reduce the number of people who are incarcerated from 1,900 in any given night to about 1,300, just since we were de-intensifying the jails. And we said, well, with racism as a public health crisis, we need to continue to do that based on our anti-racism agenda. There's some other things there that are listed. Also, one of our departments has been doing participatory budgeting. So other things that were included as part of the biennial budget that we're currently doing. And also there is a gathering collaborative that our executive has been leading with a couple of our key community leaders in health. And they're doing things around some specific funding opportunities and then consulting on our next biannual budget. If you go to the next slide. This is when I returned to public health in the beginning of 2020, as actually there's only an equity director position, but since then, and given the COVID crisis, we have created all this infrastructure that you see now as part of the office. I have a couple of or a few central kind of staff that are supporting the work, supporting both the COVID work and also the equity work within the department and in the community. And then we've had a number of different, with some federal funding and then some other grants that have come in. But really, we have created a whole new system around how do we work with community. We have task forces and liaisons. So we actually have our public health staff in each of these priority populations. So with the Native Indigenous or the Black or the East African, Latinx, really working and partnering with community during this time. And then you can see some of the other areas, either task forces or liaisons. We have cross-cutting teams, equity response team, language access team. We've been translating materials in over 30 languages. We have over 100 contracts with local translators. It's a whole new big system that we've set up. Also some vaccination programs and outreach efforts. And then I think probably what I would consider some of the most important work is the work that we're doing also. I mean, all the other areas focus with community, but really the place that's really influencing our practices and our decision-making are the Pandemic and Racism Community Advisory Group and the Community Navigators, which are really places where we they help spread the word, but they also of things that we want to share with community. But more importantly, I think they're a key feedback mechanism to really put our anti-racist practices into our policies and all of that. If we go to the next slide, you will see this is the office that we now have. It's goals around both the pandemic and trying to address the determinants of equity and social determinants of health. And really this whole thing, and I think it was so critical, our Declaration of Racism and Public Health Crisis in the middle of this pandemic to really make sure that we're embedding anti-racism into our COVID work, but then also long-term work was extremely important that really been focusing on those dual crises. And then the work that within this office we're supporting within our Department of Public Health, our equity and social justice work and racism as a public health crisis. We help in the implementation of the ESG strategic plan, and then are doing some specific things with all the different teams that you see here and that I had mentioned before. We're also doing a lot of work funding community organizations and through grants programs. But I have to say, this is all of this has been created, and we've always talked about the pandemic as an opportunity, and really we used it, and just using the opportunity also to both the momentum of the Declaration of Racism and Public Health Crisis and the expectation and demands that we had from community to be able to then do some of these things, but also we, in a way, had opportunities to recreate public health in a way that I think many of us thought that public health should be organized all along. So of course, our struggle will continue to be, how do we continue to do this even when we're not in a pandemic situation? If we go to the next slide, I wanted to cover a bit, was asked also to just get a little bit in the nuts and bolts of this too, and just developed just quickly actually this morning, just a few of these ideas that I think are important just to keep in mind in terms of how we are organized and how we're building this capacity. We've done, we do have equity teams now in each of our divisions. We have, prevention, community health services, environmental health, jail health services, and others too, that now have built teams in each of those. We have a central within our office. We have equity staff, and including an overall department equity and inclusion manager, but then also have equity, inclusion, and belonging managers in divisions. In some of the divisions, we're trying to get them in all the divisions to really be able to lead the work. So there is kind of like the central office, which is the Office of Equity and Social Justice, and then there's the department office, and then all the divisions really have dotted lines to our work, and kind of that coordination learning that happens is extremely important. We have work plans. So the way we do it is 2 years work plans. We do a check and adjust in the off year as well, and really ask divisions to really, based on the strategic plan and some of the goals that are laid out there, what are they doing in each of these different areas. And then we have, for the whole department, we also have work that we're trying to advance. I think one of the key things that has been is also we have for each, I work very closely with our department director. And we have for each of the division directors, we have accountability agreements. So actually their divisions are, and the performance of the work by division directors is held accountable by our director. Then all the division directors also share with their whole divisions, and some of the divisions are quite large. Our community health services division is over 500 employees, for example, and they share what their accountability agreements are. So their equity and social justice goals for their division with all of their employees. So I think that level of transparency and accountability is extremely important. Trainings, I think this is something right now. I mean, that last bullet is like, we're revamping our equity trainings right now as public health, but I think some of the things that have been quite successful is that we do have a basic equity and social justice training for all new employees. So when they come in, they actually know that this is an expectation. This is central to the values and principles and the mission that they're going to be doing as a public health department. You know, there's a series of trainings that we have done and the county continues to do. We have a racism training based on race, the power of illusion that covers, you know, race as a construct. I think it's a good foundational training as well. When we, after we created our equity and social justice strategic plan, we actually, through my old office, we also trained 1,700 supervisors in a 3-day building a racially just county training. And part of that was too, I was really concerned that we didn't necessarily have the experience, the know-how, the competencies to be able to actually implement such a, what I thought was a pretty bold plan that community was asking us to implement. So I think that was real, and in a way I've also found for many folks, just doing 3-hour trainings or the 4-hour trainings, half-day trainings, or even a 1-day training is not enough. So this training was probably, I think, our best training that we created, in the sense of also it was 3 subsequent months in which people had homework, they had practice, and then they would spend a full day in a training. And we were able to really get both deep into the concepts and then to the practice. We've also done, you know, for our Black and Brown employees, we've done trainings that are specific for them. A lot of the trainings, especially, you know, King County still is a majority white. We're increasingly more racially diverse, but, you know, there's different needs and different things that we can actually offer our employees based on those needs and based on their race too. So really trying to find spaces and ways to do things differently for white employees and for employees of color. And also, you know, we have a tools training, and with the tools training that we've done in the past, we used to do a 1-day training, but now it's actually better through cohorts. And we also have affinity groups and caucus groups. With that, I think that's gonna be, we're close to the very end. I know we're hitting time here. This is just a slide, and I think you'll get these slides later, just around the Pandemic and Racism Community Advisory Group. I won't cover this just so we have time here for some questions, but just an example of accountability too. We use this group to work on some of our anti-racism work and pandemic work, but really they provide feedback and they provide input, and then we use this and then report back to them in terms of our tools. And if we go to the next one, I think that we should be about, these are just some of the resources that I've been mentioning. So I'll leave it at that. Thanks.
Great, thank you so much, Dr. Valenzuela. And if we can all give you a virtual round of applause for both Dr. Bennett and Dr. Valenzuela, we really appreciate you all being generous with your time to share your expertise. And I know there's so much to unpack in the work that you're doing, and to try to package it in 15 minutes each. We so appreciate you all. They're really trying your best to stick to that, but we're so glad.
Failed miserably, sorry.
But we're so glad that you all were able to dive in a little deeper. So I know we have some time. I know there were some questions that came into the chat, and so I just want to move right into those. And if we can make your slides available to the participants afterwards, wonderful. I'm seeing nodding heads, perfect. I think that would be really helpful as well. So one of the first questions that came in was from Janet. And Janet, I would like to invite you to come off of mute and ask your question as well around funding for these positions.
Thank you, Anna. And it was during Dr. Bennett's presentation where she showed, all those wonderful positions, the number of positions. Just wondering, where does the funding come from to, fill all of them?
Yeah, at first they were repurposed. So it was half somebody's job or 3/4 of their job. In the last few years, they've been actually put into the budget. So when the city created their Office of Racial Equity, it became a budget priority. And then suddenly I could get my positions. They were one of the few things the mayor would approve. So it became a moment in the city budget.
A general fund.
Yeah, it'll go away soon, but they're in there now for good.
Thank you.
Great, thank you for jumping in and asking your question. I'm just doing a quick scan of the chat to see if there's any other questions I missed in there. And I know that there's a couple that came up. Tracy, I know that you had one about CBO partnerships. I'd wonder if you'd like to come off of mute and ask your question as well.
Yes, I really valued what you were saying, Dr. Bennett, especially through the experiences of COVID and the non-transactional partnerships. But I'd like you to talk about that a little bit more, because we also want to provide resources to folks for their time. So can you talk about that balance and how you how you perceive that and what your recommendations are?
So I'm going to give you mine, but I'd really like to hear yours, Matias, because I think it might actually be better. COVID was a concern for everybody. So we initially reached out to all of our health provider, health ed partners, and then suddenly got a lot of inundation of communication from people we were like, who are you? We don't work with organizers, children's group, like all kinds of people were stakeholders in COVID. So those groups had no relationship with us because we had not set up any kind of format of relationship that did not involve funding. And those are just hard relationships for people to be honest. And I mean, they complain a lot, so they have some honesty, but it does limit what people can say and it limits their view. So relationships with people who don't get money from us, even if they even future want some, has been a really important part. And it expands the health equity definition, right? Schools and, people who we hadn't necessarily fund are still part of equity and part of health.
Yeah, absolutely. And I think too, we also found there were a lot of important partners that we hadn't had partnerships with that were grassroots organizations. And it really was an eye opener, like, oh, this is how we, one of the pathways forward. And I don't know if Dr. Valenzuela, if you have any thoughts or insights kind of on that dynamic and that tension.
Yeah, I mean, I think, and also some of the engagement work that we did previously to create our strategic plan really talked about how community organizations often felt kind of used or not necessarily that we were establishing a relationship. So I think one is, when you talk about investing, I think about it in different ways. And that's one of our strategies, invest community partnerships. One of it is attention and focus and consistency and being able to just not turn to them when you need them. And the other part is actually putting resources behind it. So things such as, paying stipends. So, as our pandemic and race community advisory group, the group that we are asking most of, like our steering committee, our group now, our advisory group is really led by 5 community members. We pay for their time. We paid for their contributions. So I think there's trying to build those into budgets, I think is extremely important. And for us, it's a culture change. It's almost, in the past, it was assumed that people would just come and participate with us. But if we want to incorporate, especially some of the smaller organizations, I think being able to really, compensate them for their time is extremely important.
I'm going to email you and ask you how you get around the tax issue, because between the city attorney and the controller, I feel like they've made it very difficult, and I'd love to know what argument I can use. So we'll talk later.
I love these connections too. I love how you both are connecting. And I know there's so much we can all learn from one another as well. I see a hand from Vaughn. If you can unmute yourself and ask your question.
Yes, just a follow-up question for Dr. Bennett and Valenzuela. You talked about engaging community partners. I wonder, how do you, one, maintain that community partnerships on a policy level? And was it formalized? And then the second part is, how do you maintain that engagement, given that the work is long and they may not see the results quickly as they anticipate? So how do you mitigate that expectation that the world will change overnight because of their involvement?
Well, something's got to change. My argument is you better figure out something that you can change. I mean, there has to be something. So there are going to be long-term things. If you make the entire thing long-term, I just think it's unrealistic to expect people to stay with you. There have to be things that need to be changed now, partly because of the urgency. And then for us, I don't think we would have been able to be successful with the community relationships if the community hadn't changed. So there was an enormous amount of collaboration, and like people we'd only ever seen in turf wars before over funding were suddenly speaking with one voice. Huge amounts of community organizations sprang up. There's a whole Black CBO group that didn't used to exist. They got organized in order to be effective. And it's much easier to be a partner with a group that feels it has some equal weight. The power dynamics when you're just talking to one group are just very difficult to hand wave out of. Like, we promise, we really appreciate you. If you're this big and we're this big, there's only so much you can say. So when they got together, it made it much easier.
Yeah, I mean, also, thanks, Dr. Bennett. I also just was thinking around the reporting back and accountability. I didn't have a chance to really talk too much about it, but when we first started with our Pandemic and Racism Community Advisory Group, we actually had a lot of distrust in that particular space. And it was very difficult, like actually people calling us out for all the different things that we had done throughout history, but we stayed in that space. We made it really, we listened to them, and then we also came back with them consistently with what the things were, how we were incorporating their work. We put our director in that space. And then actually really, I think, rebuilt a lot of the trust in a way that things in probably less than 2 years have changed really, drastically. Just this morning with our community navigators, or just actually this afternoon, went in there because we also have, the state is repealing their indoor mask mandate in our state, but we still have a King County policy. We actually haven't decided yet on which direction we're going to go, but we went to that group and to our community navigators and asked, what do you want to see? And these are the communities, Black and Brown communities, that most been impacted by COVID, and they provide us our honest feedback. Then we are going to be meeting with our health officer to provide that feedback. That goes a long way to then actually going back to them and say, hey, this is how we used some of the information, or some of this other information we weren't able to incorporate into our policy. But I think just having that honesty is extremely important. The large part of things that I think our offices can do is increase, explain, and make our systems and our bureaucracies more, transparent, right? I mean, and just show how we do our business, and then be open to criticism, and then move people into these spaces where they can actually begin to hear. And there's a lot of change that needs to happen, I think, in our culture, because folks don't like to be criticized. And we actually prepare people, usually with my team, to like, okay, you're coming to our advisory group, don't get defensive. It's not about you, it's about the systems. It's just systems of all kinds of problems. And slowly, I think we're getting, a lot more traction in people being able to be in this really difficult conversations, both with employees and with the community.
I need to start prepping people better. They've gotten me a few times.
We still have the problem too. So.
Yeah, well.
So I know we don't have a lot of time, but I saw a few questions in the chat about sort of building on what you just talked about, Matias, about hosting conversations with staff. And I saw a few questions about hosting difficult conversations around race. And I know, Matias, you all are doing some racial affinity and caucus groups. Dr. Bennett, I'm not sure if you all also have those. I think you mentioned you did. I know some folks on the line are looking at that as a structure for their own departments. Would you mind sharing a little bit more about how those work and how those actually support the work of the department in sort of advancing racial equity? So those racial affinity and caucus groups.
We are just starting them. We have a lot of spontaneous ones, but it has been now multiple years of negotiating with HR. And for some reason, even though they exist in other departments, my particular structure had a very difficult time with this idea. And so we have lots of informal ones, including white staff and Latino staff. They put on events, but they need to be formally supported and recognized. And I've only just gotten that policy in place. And I'm not quite sure what they're just afraid of people complaining. I mean, that's always what it is in the end.
Yeah, I mean, similarly, I mean, we have created a affinity group or employee resource group policy that actually lays out, I mean, people have to have the support of their supervisors, but really lays out an expectation that people should be allowed to participate in this. We have, you know, the intent was to really make them racial affinity groups, but then we also have opened them up for different protected classes, right? So it's a much broader group of folks. I think with the caucusing, I actually find it a lot more. We've done caucusing with our executive team. There are different divisions that are doing this. We're also seeing how we can do more as a department as well. And I think some of the racial caucusing, I actually find some of that even more in terms of advancing the racial equity work can be even more effective, and especially in terms of advancing strategy and also making connections, or whether it's affinity group or caucusing. I think having connections to leadership is extremely important. I think sometimes if you set them up and don't have a venue for folks to be able to voice their concerns, I think it can become very disempowering. Some groups might not want to, have access to leadership, but to the extent that they can, I think it's extremely important to do so.
Thank you both.
Thank you both. And with that, we're running a little bit behind on time. So unfortunately, we're going to have to wrap here. But again, I just want to thank both Dr. Bennett and Dr. Valenzuela for the generosity of your time. I know that, like I said, there's so much to unpack here. We're really fortunate that you all shared your afternoon with us, and we look forward to sharing the slides and the information, and the recordings will be available for folks to rewatch later too, in case you missed something a little earlier. So thank you so much. We really appreciate you and the work that you're doing.
You can share my contact info. I've got a few new LinkedIn friends apparently, but I'm happy to unpack some of this stuff at another time or get into specifics. It's hard to do without specifics.
Yeah, thank you all. Appreciate it. Same way.
Thank you so much. And I know there will probably be folks that take you up on that, including our own team. You both are such incredible national leaders in this work. I know we all feel incredibly blessed to have you both here to share your strategies with us, and excited to unpack so many of the resources. So thank you so much again.